Direct primary care is what healthcare used to be a long time ago. And what I mean by that is really just the relationship and the trust that's formed with the provider and the patient. And to me, that still is the most important thing.
Today, we're joined by Brian Garcia, Vice President of Strategic Alliances at Nexus Health Connect and the host of the Nexus Connection Podcast. Brian helps bring together employers, brokers, physicians, and individuals to access and deliver smarter, data-driven healthcare with direct primary care at the center. Well, Brian, super excited to have you just join us today as our guest for the ICHRA Exclusive Podcast. So feel like spring is here, sun shines in the background. We were just talking about
still a little cool though.
talking about doing lawn care again, so like getting the equipment back out of the garage that we haven't touched in a while. So anyway, it's a treat to have you. So thanks for carving out some time this afternoon, and excited to talk all things kind of ICHRA and direct primary care, DPC. As just a really kind of innovative, couple different innovative solutions that can come together nicely. So we thought this was a super relevant just topic for our audience of brokers, employers, those in the insurance industry. So thanks for joining us, man.
Happy to be here and honored, actually. Thanks for having me as a guest. So
yeah,
looking forward to the conversation for sure.
I love it. Yeah, I know you've got years and years of experience kind of in the healthcare realm. I wanted to start off because we know that all of our listeners might not all know what DPC is. So if you could, I'd love to kind of just have you start with what is direct primary care and how's it different from the traditional kind of primary care that most of us are used to?
I always like to say or start off by saying direct primary care is what healthcare used to be a long time ago. And what I mean by that is really just the relationship and the trust that's formed with the provider and the patient. And to me, that still is the most important thing. So yes, I've been in healthcare for quite some time. My dad actually was a family practitioner. My mom was an OR nurse. So I've been in healthcare since I was in my mother's womb, I guess is what I always say. And primary care was, a big foundation at that point. My dad was a surgeon, but he also had a primary care practice. And I always got to see him interact with his patients, have great relationships with his patients. They all trusted him. And he was also one of those physicians that wanted his patients to have the opportunity and options to make choices with their healthcare also. So not just, I'm the doctor, you're the patient, you have to do this, but hey, these are some options. And so I think that is coming back in the direct primary care space as well, is the doctors are able to spend that time. And that's very important to develop those relationships and that trust. But within that time that's being able to be spent with a patient, that provider is finding out things that are more root cause and not just putting a Band-Aid on things. To answer your question, though, TJ, about the definition of direct primary care, the model is set up to be more membership based. And so there's a monthly membership fee, basically fairly capitated. And so you have expected costs, whether you're an employer group or an individual, you know what you're going to pay every month for that direct primary care access. And another big thing with direct primary care is the access. You're able to get access to your provider, not just, hey, I got a pain in my stomach or whatever, call and get an appointment and it's 2 weeks, 3 weeks later, but same day or next day potentially. They're able to do that because they have a lot less patients on their panel. Yep. 600 to 800, sometimes 1,000.
Which I think I've heard an average in the non-DPC model averages a couple thousand to up to 3,000 for when my dad had to start morphing into billing insurance and worrying about or being concerned about reimbursements and stuff, he ended up with a patient panel of like 4,000. We had 4,000 charts. And so, I mean, that's where his frustrations came in, was like, how do I take care of
all of these patients. There's just no way.
Yeah.
But yeah, so the average is pretty high, and that's why the fee-for-service docs can only spend a few minutes with their patients, because they have to crank through and see as many patients as possible. I actually have a brother, it's an adopted brother that's in the primary care space. And this was several years ago, but he was bragging to me like, "Hey, Brian, yeah, I saw 60 patients today." And I'm like, "Well, Mark, what kind of impact did you make doing that?" And then he was like, "I don't know."
Yeah.
And I'm like, "Isn't that scary that was your answer? I don't know."
Yeah.
So, direct primary care, again, it's giving folks access, and it's giving them access to quality health care. It's giving them the time to be able to spend with their doctor, the provider, and not just the provider typing in codes and all of that kind of stuff. The provider is able to have a better interaction with you. And then really, when you get referred out into the system, because direct primary care, you'll be able to take care of 90% of your healthcare needs with that provider. But they still have to refer out to whatever, specialists and stuff. And at that point, it's not going to be, "Oh, my buddy down the street, he could take care of your needs," or whatever. It's, "Hey, let's look for the best provider for you that you're comfortable with, that you're going to be able to get into." And, that's not just going to be there to bill insurance and get money from you. So the practice itself, or the mentality or mindset of DPC is reducing unnecessary referrals into the specialty world, reducing unnecessary ER visits, and hopefully wiping out all urgent care visits.
Yep. And then,
long answer to your question. I'm sorry.
No, that's great, man. I want to dig in. So my follow-up question, now you got my primary care brain going here on a Monday afternoon. So employers have direct primary care as an option. There's also near-site clinics, and then there's like a full-blown on-site clinic. So for our listeners, we just talked about direct primary care. Near-site clinics typically are clinic in one location where multiple employers may share the cost of that clinic. And then a true on-site clinic is where typically an employer is large enough, they've got enough patients in a specific location that they just fully fund the clinic just from that employer. So talk to me about where you find DPC tends to work really well in comparison, especially to like a near-site or an on-site clinic model.
So with the on-site and near-site clinic models, they typically or initially were designed for very, very large employer groups. And the pricing model is always, or is initially started out as like a management fee plus cost.
Yep.
So like Marathon Health was a big one, right? Especially here in town. So putting in a plug for them, I guess.
Marathon Health, Premise Health, Quad Med. I mean, there's lots of big. Yeah.
And so, they charge a management fee. That's basically their profit margin. Everything else is passed through as a cost. So they have medical supplies, staffing costs, and labs and things like that they'll pass through to the employer. What we found when we were in that space was the smaller businesses wanted something like that as well, but didn't have the critical mass to start one on their own. So there's where kind of the near site clinics started, was so that you can share with different folks. But the model itself, so the pricing is different when it comes to DPC and then those advanced primary care models. The care model is very, very similar, and they're practicing advanced primary care, practicing to the top of their licensure if it's a advanced level practitioner instead of a doctor. And the care is still there, the time is still there, the relationship is still there, and they have to be designed that way because, the most important thing, especially with the on-site, near-site clinics, is utilization of those clinics to be able to impact a health plan. And so direct primary care fits into there, but it's also, you can think about it as like concierge medicine for the masses. And not just for the executives or whatever, but you still get that access to your provider. It is different than concierge medicine. I shouldn't have opened up that wasp nest, but the comparison to the clinic space, I mean, really the mindset and mentality is the same thing. It's getting better clinical outcomes for the patients.
Yep. Love that. I love that. So kind of next question I've got for you, obviously you are a leader at Nexus. Talk to me about really kind of Nexus's role within the DPC care kind of, I'll call it an ecosystem, and the type of kind of entities that you all serve.
Yeah. So when Nexus first started, it was, almost a spinoff from folks that left the on-site and near-site world, but still wanted to stay in the space. And so it was initially to help independent direct primary care providers fill up their patient panel and be able to help them market to employer groups, whether it's direct to employer or through the benefit advisors. And that's still, a foundation of that, but really it kind of expands more to that. So the role of Nexus is still to kind of help. This is sometimes a bad term, but to help broker between the benefit advisors, the employers, and the DPC providers. But we as Nexus have a relationship with numerous direct primary care providers throughout the country. So instead of the benefit advisor trying to vet out different direct primary care providers or find them or whatever, we're there to help that way and make it very, very easy for the advisors to help provide that type of service or that type of solution for their employees. And then Nexus also gets into some of the care navigation piece. So, especially working with employer groups, trying to impact different plans and stuff, we don't want to only say, okay, here's your direct primary care provider, and then that be it. It's like, hey, here's your direct primary care provider. We're also going to work with that provider, communicate with them and say, this is the solution on your health plan, or this is where you need to go for your surgeries because your employer has a bundled surgery contract with, whatever, like a Wellbridge or whatever. They've got something that can be navigated better to help impact their health plan. So when you do look at DPC from a cost perspective, though, it's if you just add DPC on to a group health plan, and you just look at it as, okay, this is gonna save me as an employer. This is gonna save me in my for my primary care visits. And it will, because your members aren't going to have that copay. You have a capitated rate, as opposed to whatever a fee for service provider's charging. But again, the impact. So the savings that'll happen there is minimal, like 3 to 5% savings on a health plan. But the bigger impact is how that direct primary care provider is helping to navigate through the system. So we're there to help with that as well. So it's not just putting this onus on a DPC provider and adding more to what they already have to do. We're there to help kind of stand in a gap for them for that part.
It makes total sense. So I'm going to geek out here for a minute. So for listeners that don't know, my background prior to coming and joining Remodel Health about 2.5 years ago was I was working with self-funded employers and worked for a company called Springbuck, doing self-funded analytics. So helping an employer look at kind of how the health plan was operating, and then using claims data, wellness data, all these different data sets to figure out like where they should invest to ideally help better run their health plan, help drive better outcomes for their employees and their insured dependents, like all these amazing things that we would work to do. Now, direct primary care in my past life made all the sense in the world for an employer to evaluate as a really a cost containment strategy, as well as an added benefit to employees. I think it was both. It was beneficial to employees because they got better access to physicians that could spend more time with them, but it also would drive to ideally reduce gaps in care, lower claims cost over the long haul. So shift gears. Now we're here on the ICHRA Exclusive Podcast. You get an employer that they say, for whatever reason, maybe their self-funded plan has just run so poorly, they had to get out of a traditional group health plan. So they kind of moved to an ICHRA. Now they're out of the defined benefit space, where now they're just in the ICHRA is a defined contribution strategy where they don't have any more risk.
Or data to analyze, right?
Or what?
Or data to analyze.
No claims data anymore. Like they've literally moved and they said, hey, we're just going to define what contribution we want to give people. And then the carriers in the individual market that people are accessing plans from, that's who bears the risk now of the insured population. So that's a long-winded tee up to the question I want to ask you is, as ICHRA continues to accelerate, I've seen it predicted that anywhere from 1 million to 1.5 million insured members will be on the ICHRA chassis by 1/1 of 27. So this thing's starting to get kind of critical capacity nationwide. Do you see a world where Nexus is actually working with and kind of selling to the individual insurance carriers that have these pockets of insured people insured in these rating areas, that then a DPC could help deliver better kind of primary care?
Short answer is yes. Yes, I do feel that direct primary care and ICHRAs can tie together very, very, very well. Even though maybe on the surface it doesn't seem like it. It could seem like, again, here's the cost of the ICHRA, here's the cost of the DPC. So am I kind of double dipping or whatever, for lack of a better term? I'm saying double dipping, but am I paying for primary care here, but I'm still getting primary care coverage through the ICHRA? So you have to navigate that a little bit, but tying them together does work. Again, the ICHRAs are gaining a lot of traction through Nexus and our folks. We do have some partnerships with some cost share folks, like a Zion or Sedera, and you guys know all about Sedera way back in the day. And so we would tie that together with DPC, and that works well also. But not everybody qualifies for getting onto a cost share type of a product. So then we were like, okay, well, how about we have an ICHRA in place over here? So as Nexus, we don't resell ICHRA, or we're not an administrator or anything like that, but we do refer out to somebody that would be able to help take care of all that. So then they have an ICHRA on one side, a cost share on the other side, and then something in the middle that helps fund the direct primary care piece that they offer to everybody, basically. But again, tying them together, I might be jumping ahead a little bit, I don't know, but I think I used this example with you guys in our prep call.
Yeah.
So I look at ICHRAs as that's taking care of the catastrophic type events. So you utilize direct primary care for all your day-to-day needs. Well, hopefully you're not needing healthcare day to day, but I mean, so always use DPC, and then rely on that DPC to help navigate stuff for you as well, or Nexus. And then the funding mechanism for that would be the ICHRA side of things. So, the ICHRA in this case would be like the financial protection for those catastrophic events. DPC is your day-to-day stuff. The example that I brought up was kind of like an automobile. You insure your automobile, but you have to buy gas for it, tires for it, change the oil on it. You're paying cash for those day-to-day activities with that vehicle.
Yep.
That's your DPC right there. The auto insurance that you have on your cars for the catastrophic events, any accidents you get into or whatever, that's the ICHRA and the financial protection on that side.
I love that illustration. I like any illustration like that in insurance. It's not perfect, but that one's pretty doggone good.
Yeah.
Very similar to the illustration I tell every single day of like, hey, this move from a group plan to an ICHRA is like the move from a pension plan and retirement benefits to a 401k. Same concept. But I think that illustration of that day-to-day or weekly, monthly maintenance is like DPC. Versus like anytime you have to actually file a claim for your car, that actually runs through your car insurance company, because those are bigger ticket items. There's a little bit more financial protection for those things that you can't budget for.
And then even to add on to that example, like you're changing the oil, you're changing the transmission fluid, because why? I mean, that's maintenance, right? It's preventative maintenance, so your engine won't blow up. And so DPC is not just for sick care. It's not just for, oh man, I don't feel well, I need to go to the doctor. Utilize DPC for preventative stuff, like even more so than sick care. Utilize it for your health care. And, again, just like you have to maintain your car to keep it running, maintain your body to keep yourself running. DPC can do that. Again, some of that preventative and maintenance stuff is looking at root causes of things. And I said it before, that those providers have that time to be able to do that.
Yep.
So they're not just going to be like, oh, here's an Allegra because you can't stop sneezing, but hey, what do you got going on at your house? You have like 15 cats, a couple of dogs. Do you not vacuum? So why are your allergies really happening? And so, it's a simplistic example, but it's still the same thing. They're digging into why something's happening instead of just putting a Band-Aid or a medication on top of it.
Get ready for AIM 2026, the premier and largest ICHRA conference in the nation. Join us May 20th through the 22nd, 2026 at the JW Marriott in Indianapolis. Over 3 days, you'll hear from industry leaders, gaining real actionable insights on market trends and strategy, and be able to connect with the nation's leading brokers, carriers, employers, and industry innovators who are driving the ICHRA movement forward. Head to remodelhealth.com/AIM 2026 to register. One of the other things I wanted to pick your brain on that gets me excited for how ICHRA and DPC work together in the future is the legislative change that rolled out 1/1/26, where now for the first time, individuals can use HSA dollars to pay for DPC costs. Finally. Yeah, it took us way longer than we had hoped. But even in my family, our family, I'm married and I've got 2 sons. So we are Remodel. We like to say we drink our own champagne. So we administer our own ICHRA plan for our 200 plus employees. So we all kind of are on ICHRA ourselves. So for our family, it made sense this year. We actually bought a bronze level plan, individual plan, with a higher out-of-pocket maximum, higher deductible. And then we kind of max out our HSA contribution. And one of the ways that we choose to use our HSA is my wife values a DPC subscription. So she's got this DPC for her. I've decided at this stage that I don't need that. So it doesn't even have to be for an entire family. Me and my boys actually don't elect to subscribe to DPC, but for my wife, and maybe she's smarter. Actually, I know she's smarter than me. She's investing more in the maintenance.
See, that's
of
why
her
you should
health.
go on DPC too.
Yeah, I should consider it. I agree. I'll try to consider it again for next year. But it's this whole idea of choice, true choice. Yeah. So you said, what I loved you said earlier is DPC is a way that it's like advanced primary care for the masses. And I think that the ICHRA framework and the new HSA legislation is hopefully going to open up DPC for more and more and more people. So I'd love to, if you would share, what does growth look like at Nexus, even after this initial kind of ruling where now those HSA dollars can be used for DPC?
Yeah, it was... that was exciting news, obviously. It was a step in the right direction. And again, finally. It makes sense. It's a no-brainer that you should be able to utilize your HSA dollars for that. I also think that the Medicare space, really needs to open up and be able to let Medicare folks utilize direct primary care without being penalized in whatever way. Growth wise though, we as a company, as Nexus, we try to focus and make sure that everything is focused around direct primary care, direct care in general. So cash pay, whatever, on the front end. And so our growth is going to be more along the lines of, again, still helping DPCs fill out their patient panels, but not relying solely on whatever you want to call it, a spread between what we charge per member per month and whatever discount we got from a DPC, but more along the lines of helping those DPCs, but not messing with their per member per month pricing. But we add, again, that navigation layer, any other kind of advisory type layers on top of that. I think that the legislator can probably even do more when it comes to DPC. I mentioned it already with the Medicare stuff. I think that states should really get into looking at the capitated payments. I mean, look at the Medicaid crisis we have going in just the state of Indiana, or not a crisis, but I mean, it's getting tight, and funding is getting tight and everything, and still there's a lot of the term being used nowadays, I guess, is the waste, fraud, and abuse. But I mean, whether you think that it's there or not, there is definitely waste. Maybe not the fraud or abuse, but there's definitely waste in how things can be paid for that way. So I think growth, not just for Nexus, but just the industry as a whole, might be in that space as well. I also think from the ICHRA standpoint that, and I hope, I guess, I mean, I think everybody was hoping that the legislation and the big, beautiful bill would have been a lot more friendly for the
There were a lot of things in there that didn't make its way through.
And I wish that some of them would have, and because that's the scary thing, I guess, that I look at from the ICHRA standpoint is one or two presidential elections can really send this thing upside down.
They can, but here's the thing I always say is, like, really it's bipartisan, because you have, like, this one of the few things that I would say both sides agree on, that
so then do something about it.
So. And I think they have. It just maybe not as fast as you or I would have liked it, but I do think that in general, both the left and the right side, wherever you're at politically, I think both sides agree that this whole idea of giving more of the consumer the choice is a good thing. Now, the exact mechanics of how both sides would have it rolled out, maybe they don't see eye to eye on that. Yeah. But I think that ICHRA has been the best middle ground that, like, both the left and the right side agree upon. Like, hey, man, this thing's here to stay. The employer adoption of ICHRA has accelerated. In general, I think both sides agree it's a great thing. So I'm not worried about ICHRA going away. But like getting further, like making it so that, like, we can smooth out the edges of how ICHRAs get rolled out. So now you're going to get me on my soapbox. So, like, things like COBRA, like why in the world does COBRA even have to be administered when an employer offers an ICHRA? Because these plans are individually owned and they're portable. So if an employee is no longer employed by their employer, they lose their ICHRA contribution. But they can just take over making the full payment of their plan by themselves. Like, you shouldn't have to administer COBRA, because no one in their right mind would want to pay 100% of the plan plus a 2% COBRA fee. But you still have to administer COBRA when you offer an ICHRA. So it's just some of those little, like, details like that I think we will, like, work through and smooth out. But that was a huge win that, like, HSA dollars can now be utilized.
Absolutely.
And I think that we're just in the like, to use a baseball analogy, we're in, like, the bottom of the first or the top of the second inning, I think, for how especially brokers are going to think about DPC and ICHRA together. I would also say, as ICHRA moves up market, like we've seen the amount of employers that we serve that are truly middle market employers that are 500, 1,000. We've got an employer now that's almost 5,000 eligible that we administer an ICHRA for. The more up market this moves, you've got employers that have made advanced primary care a part of their health plan strategy for years and years and years. They're not going to just rip that out from people.
Right.
But like a near site or an on-site clinic, if they move to an ICHRA, might not make as much financial sense. DPC is such a nice alternative where you can still make that available to people that value it. But maybe you don't have to fully fund an on-site clinic where it doesn't make as much financial sense when you move away from self-funding, for example. So I get really excited about it. I think DPC is such an incredible strategic lever that the best consultants and HR, like, leaders can think about as part of their overall kind of benefit strategy.
And even outside of the benefit strategy, I mean, just an HR strategy in general as well, or as a whole, think you went over it a little bit earlier, but I mean, providing that type of a benefit to your employees. Well, number one, you already said it. If you yank it out from or away from them, it's gonna be a mutiny, right? I mean, they're used to it. They love it. They want to use it. If you take it away, it's not going to be great. But that benefit can also be utilized as a recruiting and a retention tool.
Yep.
So, from a cost perspective, I mean, you guys hire people all the time. You know how much it takes just to recruit and train and hire somebody.
Yeah.
And so if you can start eliminating some of those costs, I mean, that helps out.
Yeah.
And so, yeah.
It is interesting, though. I don't know if you've seen, I just saw it this week. Lockton, one of the biggest national brokers, just published their 2026 benefits survey. They had over 1,700 administrators complete this survey, and it showed over time the most important, did admins value retention and retention of their benefits plan is more important, or cost savings. And it's like this giant X where you looked at like 2018, 19, 20, it was almost all attraction and retention. Well, that's now shifted where 54% of the survey people that they surveyed, they said cost containment is now the number one priority, and like attraction and retention for employees has dipped significantly down from cost containment. So I do feel like we're in this weird moment in American kind of health insurance, healthcare, of where it's like enough's enough, and people are finally just being super honest about like what's most important to them. So it's like, you want to still offer benefits that are like highly valuable, but it's also like, man, I feel like people are starting to be honest and say, no, my number one most important thing is I got to keep the lights on my health plan, and like cost containment is critically important.
Yeah, and I mean that's the perfect mentality to implement ICHRAs, right? Because you've got at least a capitated payment or a payment that you can budget for, and so it's not random costs here and there wherever, and or not all of a sudden some kind of a cancer or a heart event, or so a catastrophic event that now you're gonna have to worry about that and jump in your health plan. I mean, ICHRAs take that business completely out of the insurance business or the insurance world, and that's definitely helpful for a lot of folks. One thing you mentioned about the ICHRA being portable, direct primary care would also be portable. Right with that ICHRA product. So.
Yep. I love that 100%. So last major question I've got for you today. So I always try to give people like something to sink their teeth into. So to frame this question, so if you're talking with an employer, or you're meeting with a broker partner that's trying to really grasp DPC and Nexus, what are some criteria you would say, hey, if you have a group that has X, Y, and Z, they would be great to evaluate DPC? And then the other side of the coin of like, what are the types of like things, maybe it's based on where an employer has people located. What are some of those things that you're like, that might not be a great DPC candidate? Would love to hear you share with our audience what to look for, and then maybe even more importantly, what not to look for as a consultant or an employer leader would evaluate where DPC works and where it doesn't.
Yeah. So, the biggest things are, our lens of success at Nexus is anytime that we can get one person utilizing direct primary care, that's a success milestone for us. Because that leads into, if it's a big employer group or an employer group, that leads to word of mouth. So then other people are going to be able to start utilizing it, or at least be interested in it. So that helps. And again, we're there to help out with that member experience. The good candidates for DPC really are, anybody and everybody needs access to good primary care.
Okay.
No matter who you are, you do. And again, it's not just because of sick care, it's because of that health care. So we want to help to really create better clinical outcomes and health outcomes for folks. So not just get them that access, but help and keep them healthy. And so, candidates for direct primary care, advanced primary care really is anybody out there. that wants a health care product, and again, tying that with the health insurance of like an ICHRA or whatever, but benefit advisors that are looking at different employer groups, spread out employer groups can still have access. And again, working through Nexus, there's where you don't have to sit there and try and source out one provider or whatever. We could have, even in Indianapolis, we could have 10 different direct primary care providers with one company. So then that DPC is closer to that person's home or whatever, and not just closer to their work.
Yep.
And so it's not just like a one or nothing.
Yeah.
Now there are
talk to me about some pockets in the country where, like, I would almost call it like the DPC network isn't as strong, where they can be trickier.
Yep. Perfect. Thanks for teeing it up. There's where I was going. There are DPC deserts, I guess is what we call them. So there's no bricks and mortar physical clinics anywhere. And I mean, there's a lot of reasoning for that, I guess. I mean, there's maybe just not some of the critical mass that's there. Maybe just, just no providers at all whatsoever. And people have to drive for their care. There are companies out there that are trying to alleviate that or help out with that. So they're have like a direct primary care type of a model or a product, but they're going to visit or going to a person's house. Type of thing to do their primary care visits.
Traveling DPC. I didn't even know that was a thing.
Again, am I allowed to say names?
Oh yeah.
Okay.
Yeah.
So if you look at Nice Healthcare, they're coming into Indiana now. I believe that they've put a footprint in Indiana, but it's virtual primary care. Virtual first, then if you need a physical visit, then the doctor or provider would go and visit that person and take care of them. But there's other companies like that are sprouting up as well. Now, Nexus has a sister company to help alleviate, if we run into an employer group, Rockport, Indiana, or Rockford, Indiana, I think. I mean, there's no DPCs around there whatsoever. And so we're proposing that they utilize our virtual direct primary care product. And it's virtual only, so we won't go on site anywhere, but it's virtual urgent care and virtual primary care. And so that can be like their choice. Again, if it's the employee wants to choose that, then they can. Or we could say, we do have a DPC provider that's 45 minutes away, not 25. Are you okay with that? And if they say then we'll get them set up with that type of a clinic. But again, so DPC we feel is for everybody, but it may not be accessible to everybody in the country.
Which is very similar to how I talk about ICHRA. ICHRA, the reality of ICHRA is only as strong as the individual insurance market in where your employees live. Mm-hmm. So example, and this is not a perfect example because we have Chicagoland clients, but Chicago, for example, very tough ICHRA market. You've got fragmented networks in Chicago area, and prices of individual plans are really high in comparison to other areas. So I tell consultants I'm working with in Chicagoland, it's a tougher ICHRA ecosystem versus other areas where just north of Chicago, you get into most of Wisconsin, most of Minnesota, incredible ICHRA markets in most of the areas in those states. So it's very much like pocket to pocket. I think there's some truth to that in DPC, but it's being further developed every month that goes by as DPC continues to grow. And I think same is true for ICHRA. You've got more and more individual carriers that see these markets have a need for better product, and they're trying to bring more and more solutions and options to the individuals that are looking for better insurance plans in some of the pockets that I'd say maybe aren't great right now. Yeah. So
on the DPC front too, though, you do have providers out there that want to get out of the system. They want to get out of the fee-for-service world. They just don't know how.
Yep.
And there are companies out there that can help do that and help guide them.
Yeah.
One big thing is the financial hurdle. Okay, I'm going to lose all this fee-for-service income. What am I going to do to make any income until I build up my patient panel or whatever?
Yeah.
And so there's mechanisms out there that kind of help front load the financing as well. So it's getting easier and easier for providers to get out of the fee-for-service world, get out from under whoever owns them, if that's the case as well, and becoming independent again and doing it from a direct primary care space.
Yep.
and then I guess one thing that always gets brought up to us sometimes as well is, well, there's a DPC right here and there's a DPC right here, just right next to each other. Like, aren't they competitors? And I mean, it's almost like yes and no. I guess maybe they're competing for some patients or whatever, but they're going to cap their patient panel,
right?
So
they've got a capacity. Once they're there, they're there.
Yeah. So they're not going to sit there and go after as many patients as possible. So they're not going to sit there and poach the DPC down the street. They're going to support that DPC down the street. So it's an industry as a whole is rising.
Yep.
Yeah. And ICHRA space as well, right? I mean, you guys are rising and really getting more and more prominent. Education's getting out there, and podcasts like this, I think, are great to get that word out as well. So
I love it, man. Well, it's been awesome. Last question I've got, I ask every listener this. So put on your future facing hat. If anything could change in the next, call it 5 years, specific to ICHRA, what would you love to see changed? I know there's a lot.
There is a lot. I was trying to go back to something that you said earlier, TJ, about even like setting it up and designing it to be like someone's 401k, but even funding it, having a funding mechanism, something like that for ICHRA. It's just even making it more easy to get into that space for folks. Education, I brought it up before, just making sure that people know that this is something that's out there. And it's I mentioned that it might go away from a presidential election just because of the executive order or whatever. You don't feel that way, which is awesome. I feel that it also, though, if it does get somehow codified or whatever into something, then just the market will explode big time. And I really think that, there's situations obviously that in ICHRA probably won't work, but there's a lot of situations where it's just great. I mean, it's definitely a good product. I said it earlier, it gets the company out of being in the insurance business as their secondary business. Yep. And then gets them out of that risk as well. And you're just even the fiduciary liabilities that come with all of that too. Yep.
100% +1 to all of that. And I think too, the more ICHRA accelerates, so I feel like we've had major acceleration in knowledge of brokers, also knowledge for employer leaders and HR staff know about ICHRA more and more and more. Yep. What I want to see next, the next layer is I want the everyday employees to know that ICHRA is an option, because I think the more and more employees go to their benefits leaders and they say, hey, why are we not considering an ICHRA for our health plan? It would open up so much more choice for me. I feel like that's the next layer, where the more and more I can just walk on the street and survey random people and say, hey, do you know what an ICHRA is? My dream is that 3 to 5 years, I'd survey people on the street and be like, oh yeah, I know what an ICHRA is. It would give me pre-tax dollars and I could go pick the plan that works for me and my family. That, man, once we hit that, I feel like it's just going to accelerate all the more. Yeah. But insurance is complicated. It is. So I think we've had some major steps forward in really a short amount of time, because ICHRA's this is the start of the 6th year of this being a thing. So I think that we want to keep driving and pressing for growth, but I think we've had a lot of growth over the last 5 to 6 years too. So
because sorry, I'm continuing on, but along with what you were saying, just being able to get that choice, as even benefit advisors, as they develop group health plans, I mean, it's always the case that group health plan is not going to be right for somebody or several people in the company. And ICHRA's eliminate that as well. So just, again, the education for people to know that. Yeah. And then you also had mentioned that you went with a bronze plan with your ICHRA. Again, tying a bronze plan to DPC is fantastic.
Yep. So. Yep, 100% agree. And if you have never seen if you like The Office, and you're a listener and you've never seen The Office health insurance episode, go watch it. You'll thank me later. You'll be rolling, laughing. But it literally hits on, this was The Office years and years ago, hits on the problem that ICHRA solves, where the office employees had to try to pick a health plan for everybody. So you just made me I'm thinking through Michael Scott and all the Office actors kind of acting that out, because, man, it's just hilarious. And so
now I got to go watch that episode.
Yeah, go check it out. So anyway, Brian, appreciate you being our guest, man. This was such a treat.
Yeah,
and
great to be here.
Take care, man.
All right. Appreciate it. Thanks.